welcome in today's nursing webinar session. Myself, Shanti Bhattacharya, the Vice President Nursing, and again, your webinar moderator today. Today, we are going to talk about the very interesting and very vast topic on acute coronary syndrome and its management. So, as you all know, we are talking since the past week. We are talking a lot about cardiac conditions and its management. So today the third topic which we are going to discuss about ACS, and I'm very delighted to introduce our expert panelist, Dr. Jeethender, who is from Yashoda Hospital, Hitec City, who is our senior interventional cardiologist. And let me also acknowledge that he is our all nurses' favorite too. His interventional skills and marvelous patient care cannot be just described in few span of time. I welcome you, sir.
Thank you, madam, for a kind introduction, and I welcome you all to this wonderful webinar.
Thank you, sir.
I welcome you once again from the Yashoda Group of Hospitals.
Yes, sir. And let me also introduce our very talented and dedicated, very helpful in nature, none other Miss Deepika, who is from Somajiguda, Yashoda, and she's working as a nurse manager in cardiac unit. I welcome you, Deepika.
Thank you, ma'am. Thank you so much.
Start sharing the slide. Yeah, next. Yeah, so this we are just going to talk about the prevalence. It is derived from the very trusted source, which is the AHA. Nearly 1.5 million hospital discharges involves patients with ACS. 18% of men and 23% of women over the age of 40 dies within 1 year of having the initial recognition of MI. So the insight about you, sir, about this, how common is ACS in Indian scenario?
Yeah, if you look at the ACS, like acute coronary syndrome, it's nothing but whenever a thrombus or, whenever the clot forms over the blocked vessel, like a vessel, there are three vessels in the heart, which supplies, the blood to the heart muscle. So whenever there is any blockage, like total 100% blockage to any of the vessels which supplies the heart, you call it as the epicardial vessels. So it could be an LED, it could be LCX or the RCA, which are the three vessels which supplies the heart. So whenever there is a 100% total occlusion because of a thrombus formation in that vessel, it gives to a condition like you call it as a myocardial infarction. So if you look at the scenario before the COVID, generally this acute coronary syndrome used to happen in 50s and 60s. But now, after the COVID era, the number of cases of myocardial infarction has increased dramatically. And especially the youngsters, the 20s and 30s also, even if you're not heard before, like having a heart attack, you're seeing so often in the news having an attack. So the numbers have increased. It is because of various risk factors, which I think Deepika will be discussing on the various causes and risk factors of that, which will be going to detail. So of course, the numbers have increased, and I think it is an alarming sign, and we always have to be ready to deal with that particular situation.
Yes. Next slide. As I think at our facility, we always believe that any patient who has the symptoms of pre-attack or heart attack or unstable angina, our beautiful scenario describes that the patient or our facility should be rushed for this ACS protocol, and before it is too late, let patient approach us before it is too late. Yeah, next. What slide? Deepika, the next of the session to you.
A very good afternoon to one and all. Today we are discussing about acute coronary syndrome. It's an emergency condition where to sudden reduce blood flow to the heart.
So sir, again we would like to know here, in spite of having fast track system, like yes, at our facility and any other hospital, like, do you also experience that pre-hospital scenario, the client or the patient must have consumed a lot of time, and it is, again, linking with the mortality and morbidity because before the patient reaches to the hospital?
Yes, it's a very golden period. As you rightly said, acute coronary syndrome, what Deepika was saying, is an emergency condition, like a patient having symptoms like chest pain at his home or somewhere else, and he is trying to reach the hospital. So I think once reaching to a tertiary care or a nearby hospital, it takes time because of the traffic and other things. So before that, I think always one need to diagnose whether it's a heart attack or not, which again we'll be discussing subsequently. But before that, I think this is a golden time, I think, which should never be lost. And I think pre-hospital diagnosis and treatment, especially the nursing or whoever the technician is available, at that particular scenario, is very important because it buys time for the patient. So the earlier you intervene, the earlier you start the medications and give like whatever the antiplatelets which we'll be discussing, that will help a lot for the patient.
Yes. Okay, next slide, Deepika. Next slide. So again, we were trying to understand that is the age a primary factor, sir? I mean, when we see sometime is age a single primary factor, or a woman with menopause, or maybe the wellness of woman is not being taken care and she's just like, having a lot of insomnias. So is this a relative contributing factor for women's contracting heart attack?
Yeah, if you look at the sex, like males versus females, of course, the unfortunate thing is males are the scapegoat. They are at a higher risk of getting a myocardial infarction. But females, if you look before the menopause, it is because of the hormonal milieu which you have, especially the estrogen and progesterone. It has got a protective effect on the heart. So that's why you rarely see, the number if you see when compared to males, females before the menopause, the risk of getting an MI is less. But once they attain menopause, like after 45, 50 years, once the estrogen and the progesterone, the protective effect is lost, then the risk of male versus female will be the same. So I think at this particular junction after menopause, females has to be really careful about their lifestyle, about their, the comorbid conditions which they have, like diabetes or thyroid, whatever is there, or the sleeplessness, what you said, insomnia. So all these multifactorial things play an important role in development of these ACS.
So do you, a woman who comes with the cardiac signs or any kind of chest discomfortness, do you also suggest or refer the cases to the gynecologist for the artificial hormonal therapy, or she should consume or she should take as a prophylaxis dosage for the women?
What?
Artificial hormonal therapy.
Yeah. So previously, like what you said, for menopause, once they attain menopause, hormonal replacement therapy was the norm. But, with the hormone replacement therapy, there are a lot of, increased instances of malignancies, especially with estrogen. So that is why now hormonal therapy, I think it's not a routine mandate in many of the centers, especially in any of the centers around the world. So only like when they have a lot of, hot flushes or typical menopausal symptoms, I think at that particular time only with the under supervision of gynecologists, they decide whether they have to go for hormonal therapy or not. But in routine, it's a no.
Yeah, continue, Deepika.
ACS is of three subtypes: unstable angina, and STEMI ACS and STEMI ACS. In unstable angina, there is a reduced blood flow to the heart. In STEMI ACS, there is a partial obstruction in the coronary artery, and STEMI ACS, there is a complete obstruction in the coronary artery. And risk factors includes smoking, diabetes, hypertension, hyperlipidemia, poor nutritional practices, physical inactivity, and obesity.
So any other cardinal signs apart from this risk factor, sir?
Digestion.
Deepika, can you go to the previous slide? That picture of...
Go to the previous slide, yes. Yeah. Yes, is this or fifth one, sir? The ACS subtype.
Yeah. So if you look at this slide, there are three very important, neatly depicted pictures. On the left-hand side, you can see this is the coronary artery, and you can see the yellow one, this is atherosclerosis. So it's a cholesterol debris, which does not start in a daytime. It happens over a period of time. So whatever the LDL cholesterol, whatever the excess cholesterol is there in the blood, it slowly gets oxidized and gets deposited in the walls of the arteries. So this goes slowly and try to obstruct the lumen of the vessel so that the blood flow to that particular heart muscle of the particular territory will be decreased. And whenever there is a reduction, like more than 70% reduction in the blood flow, at that time only the patient will have symptoms, like I said, chest pain, or breathlessness, or sometimes palpitations. So these are some of the cardinal symptoms of, of a heart issue.
Yes.
So on the left-hand side, if there is like decreased flow, you get an unstable angina. Or whenever in the middle side, you can see if there is like partial obstruction with a superimposed thrombus, but not 100% occlusion, you get some necrosis to the muscle. And because of that, the blood markers like troponin and CKMB will get elevated in the blood, and you call it as non-ST elevation MI, because the ECG does not show any ST elevation, rather than it shows a depression or a reciprocal ischemic changes in the ECG. On the right hand side, you can see that epicardial vessel, there is a cholesterol blockages there, and superimposed, there is a total thrombus, which is totally obstructing the lumen. So there is 100%, occlusion of that particular vessel, which supplies the muscle, and there is a necrosis which occurs transmural, like a total thickness of the wall is affected, and patient has an ST elevation on the ECG. So you call it as an ST elevation MI, which we are interested in treating that. And I think this is the golden period where we need to be really careful and try to prevent less damage to the heart. So that is the whole goal. So the whole goal is whatever the thrombus has formed in this vessel, we need to clear it off, and we have to restore the flow within 3 hours of time, so that the damage to the heart muscle is minimized.
So STEMI will be the PCI criteria, the coronary intervention criteria. Yes.
Yes. So whenever the vessel is occluded, the whole concept is we have to open this vessel within 6 hours, which is the maximum duration, or sometimes you can go up to 12 hours also. So the earlier you try to open up this vessel, with the help of a wire or a balloon, which you do in a cath lab, try to open up the vessel and put a stent across, so that the flow to that particular vessel is restored back, and we are able to salvage the myocardium, so that the patient can have a decreased, damage to the heart and decreased LV dysfunction.
Very clear-cut description, sir. Thank you for that. And Deepika, over to you for the next slide.
Yes, ma'am.
Now go to the 7th slide. Yes. Now go to the 6th. 6th one, the risk factor. Yeah. Sir, as we were discussing about this risk factor, do we also have any cardinal signs or any other cardinal risk factors apart from this?
So the traditional risk factors, I think Deepika has mentioned, like the most common is the habits like smoking, like having an excess cholesterol. Obesity is one thing which is also equally important, and along with that, the other thing which is not mentioned, I think, on the slide is stress.
Yes.
So having a prolonged stress like thing, like because of job or because of the other issues, also a prolonged stress, sometimes it can have a plug rupture, and patient can have an MI of that. So that is also equally important in today's scenario after the COVID.
Yeah, so we try to describe the stress in the contributing factor, which will be again coming for the next slide. Yes. Next, Deepika. No, go to 7th. Go to 7th. Yeah, symptoms.
Let's discuss about the symptoms: chest pain, chest discomfort, indigestion and syncope, nausea and vomiting, pain in the arms that is radiating to the jaws, shoulders, and sweating, weakness, and SOB.
So here the indigestion is often misunderstood as a heart attack, maybe a common couple or common individual at home, maybe elderly, or is this should we think that the patient is experiencing or the person is experiencing pre-heart attack, or is this a right to think that they should come to the hospital?
Yeah, so I think this is a very important point. Heartburn is one of the mimic of heart attack. So every patient, like whenever you have a heartburn, you take a Pantop tablet or Rantac or something like that, and try to while over the time, if it is an MI. So that golden period is lost if you stay at home, like you're someone in the elderly family having this issue, and you waste away those couple of hours, which is crucial for that time. And when you come to the hospital, it's already late. Patient can have an arrest and patient can die also. So this mimic, I think, not all heartburns are heart related, but always you need to check it. You need to be cautious, like patient, as I discussed before, having risk factors like diabetes, smoking, having a continuous stress, sugars uncontrolled, hypertension uncontrolled. So all these risk factors, if it is there, if you have a symptom of heartburn, better to get an ECG done early, consult a physician or a cardiologist if you have a nearby facility. Try to see that there are any changes in the heart or not. If it is nothing, then most of the time it is not a heart related. You can go away with a simple antacid or a gas tablet like that.
Yes. Yeah. Yeah, over to you, Deepika.
menopausal stage, and inflammatory level.
Okay, so we have already discussed about the menopausal stage and the other possible contributing factors. As you were saying about the stress level also, I think this is the most contributing factor nowadays in the this era. Yes, next slide again. Next slide, Deepika.
Immediate investigation is ECG. In normal ECG, when we compare it with the STEMI or non-STEMI, there is ST elevation in STEMI ACS and ST depression and T wave inversion in STEMI ACS.
Yeah, as I've already discussed regarding the ECG, the same thing. The important thing is whether it is an ST elevation MI or a non-ST elevation MI. Why is it important? Because the management is different. So if you look at the ST elevation MI, the management will be either a thrombolysis or you're doing a primary PCI or angioplasty. Whereas if it is a non-ST elevation MI, it's not. If the patient is having pain, then we take him to the cath lab, do an angiogram, see the vessel blocked, and then we open up it up. But if it is in like an acute unstable angina, where there is not a total blockage, you can initially stabilize, give the patient some time. There is some time for your intervention, and the patient will benefit with that also. So early diagnosis is more important. Like you said, the ST elevation more than 2 mm, or there is an ST depression or T wave inversions. So all these signs has to be picked up by the nurse or by the person, the student who is attending that particular patient.
Yes.
The cardio biomarkers that are helped to rule out for STEMI and STEMI is tropi and CKMB level. Elevation of tropi level we can see in within 6 hours, and CKMB is a normal 0 to 5 ng per UL. It's elevated CKMB level we can see, and 3 ml plain sample we have to collect, and we have to send the sample for these 2 enzymes.
So I think these are the very foremost cardio enzymes test which we are supposed to send within no span of time, and I think this is only we practice. No, sir. Maybe your insight about this.
Yeah, the important biomarkers what we routinely do nowadays are the tropis. It could be tropi or troponin 3, but we have like high sensitive troponin also, which is also available in the emergency, which will detect even minute amount of attack also. So which is very sensitive marker for for the diagnosis of non-ST elevation MI. So which are also kits available in the emergency. So always, even though one more important point is, even though the tropi is negative initially, but the patient is having chest pain, we have to repeat the sample again after 60 to 90 minutes. Don't send the patient home. Try to keep in monitor. Try to keep his ECG leads in situ, his blood pressure, the cuff, everything as a nursing student.
Yes. If you look at the image also here, Deepika, we are just go to the previous slide. We can see the H, which is nothing but correlatively it is showing these signs of hypoxia, and here it is necrosis. Okay, as sir has already described. Yeah, next slide. Yes. Hello. Hello, Deepika. You're there? Can't. Okay. Go back to the Deepika. Am I audible to you?
Yes, ma'am.
Yeah. Have you spoken about this slide? Because it was not audible to me.
Yeah. Yes, sir, ma'am. I have spoken.
Sir, have you heard, sir?
No. You can repeat it.
Please repeat.
Yes, ma'am. These are the 3 cardiac enzyme, and its time of initial elevation and time of peak elevation and time to return to normal.
So, sir, when we are looking at this diagram, which is again onset time of peak of elevation and the time to return, like to the normal. So let's say one patient comes and post-discharge patient goes home, and maybe the patient, these are 3 to 10 days or whatever time duration. Do we advise a patient to resume the normal work activities, or should the patient wait?
If he has a chest pain?
Yes, sir.
Yeah, if the patient after doing after having an MI, once the patient is discharged, we cannot rely only on the markers, because most of the markers, like what you are seeing on the slide, it returns to normal within 3 to 4 days. like CKB and myoglobin, which it becomes normal. So that is why if the patient comes later, we may not be detected with these biomarkers. Rather than the symptoms are important. If the patient has continued chest pain, again we have to repeat the sample. Maybe again patient has a fresh necrosis, and again the CKB values or the troponin values again may get elevated.
Yeah, next. So we always want to give the awareness that we always run with this fast tracking system. Like as you see a patient, we might see the patient right from the onset of symptoms of STEMI or NSTMI. The EMS dispatch and EMS comes to the scene, and then there is a nurses always try to fix the detailed lead ECG, and again triage plan, everything is done, and then if it is a non-PCI capable or PCI capable, again your intervention comes here. Loading dose of anticoagulants may be given at ER or shift to cardiac cath lab or maybe ICU. It is all total, this triage plan and the assessment of the patient sticks on the multi-team dynamics at the ER, ICU and cardiac cath lab. The golden hours, I think, sir, you may also be agreed that 30 to 90 minutes one should not ignore, where every second counts. The nurses should be very quick and very prompt in the interventions. I think everybody will agree for the same. And next slide, Deepika.
This is the best practice we are using in our hospital is the ACS algorithm. When patient came, it's take ECG and vital sign. In ECG, we have seen ST depression or T-wave depression. We have to take criteria for NSTEMI and send troponin. If troponin is positive, we have to follow all the criteria of NSTEMI, immediately inform to the team whether as per their advice, we have to shift the patient to ICU or cath lab.
Next.
Very true.
Yes.
This onset to door time denotes the time between the arrival of a patient with a STEMI in the emergency.
So I think, sir, this is right, no, that less than 30 minutes, we all need to act right from onset to needle time. Yes. Next.
So the door to needle time is thrombolytic therapy.
Yes.
Within 30 minutes, if we give a fibrinolytic therapy, the chance of opening up the vessel is very high.
Yeah, yes.
Door to balloon time is when a patient is in cath lab, catheter guide wire crosses the lesion in the coronary artery. It is less than 90 minutes. The total ischemic hours is less than 2 hours.
So within 2 hours only, we all need to intervene for the safety of the patient. Yes.
So the earlier they open up the vessel, the flow is restored, the better will be the result for the patient.
Yes.
So within 90 minutes or maximum up to 6 to 12 hours also, if the patient has pain, the result will be there for the patient.
The management is mainly angioplasty and stenting. Is depending on the patient condition, they may go for coronary artery bypass.
Or the angiograms, sir, I think this is the likely management. These are procedures we need to perform. Next.
So angiography, like I said, the primary angioplasty. So where we the culprit vessel, whatever is there, we try to open up with a wire, do a balloon, establish the flow, and if there is a lesion, we put a stent across and open up that culprit blockage.
The loading doses of anticoagulants is atorvastatin, aspirin, disprin, clopidogrel, and fractionated heparin.
So this is important slide, I think, from management of nursing point,
Yes.
which I want to stress upon, because whenever a patient is being taken for an angioplasty or a thrombolytic therapy, all these 3 drugs has to be given to the patient. Okay, the first one is the acosprin, which is important. You give a loading dose of 325 milligrams. Second one, this is the antiplatelet. Second also is the antiplatelet. So there are the 3 P2Y12 inhibitors. One is the clopidogrel, which you give a 300, or sometimes you can give a prasugrel, but we don't practice nowadays much. Rather than the most common molecule we use is ticagrelor, which you give 180 milligrams, that you get of 90 milligrams tablets. So 2 tablets you can give it to the patient. And third one is the statin, either atorvastatin or rosuvastatin of 40 milligrams. So all the 3 tablets has to be given along with the anticoagulant of heparin of 5,000. So these 3 things always before the patient is being shifted to the cath lab, all the nursing students have to make it a point that all these drugs and the injectables are given to the patient. Otherwise, what happens if you do a PCI without this, the chance of getting a stent thrombosis is very high. So never lose this loading dose. So with this, almost 50% reduction in the symptoms will be there for the patient before we take them for cath lab.
So these drugs are always kept as a part of emergency inventory. So nurses should always act quickly and administer these drugs without any, intervention. Yes. Next.
Mononpneumonic is a morphine, oxygen therapy, nitrates, and aspirin. If patient is having any pain, we can administer morphine. Patient is maintaining less than 93% of oxygen, we can start immediately oxygen therapy.
So, sir, this mononpneumonic, I think it was a traditional method. Now also, I think the sequel of the same is being followed. So I think we all should practice the same mononpneumonic when we receive the patient.
True.
Next.
Nurse's responsibility is nurses has to follow all 6 IPSG goals, and all pre-op and post-op instructions are advised by the cardiologist. Always to make sure that cannula should be kept on the left hand, that is 20 gauge cannula, and make sure if patient we are shifting from the ER to cath lab, we have to shift the patient with a defibrillator.
So here 2 important points. One thing is cannula is very important, like she said 20 French. Why? Because whatever the drugs we do during primary angioplasty, we give through this left cannula only. Suppose the cannula is not working, if you give an anticoagulant like heparin, it will not go into the blood. So whenever you do the procedure, no, we will get a guide thrombosis or a stent thrombosis, and patient can collapse on the table. So that is why the nursing role here is very important. You should always see that the cannula is working properly. You should double flush it, see that it's working properly. If it is not doing, you can keep on the right side also sometimes, because the reason why we don't do it on the right side, because we do radial angioplasties, we do from the radial approach. That's why we don't advise. But it's not like a strict one. If you don't have a left cannula, if there's no other access, then you can do it on the right side also, provided we can keep a connector and they can attach to a, the slide one. And the other thing is defibrillator is also important. Why? Because some patients can have VTVF, ventricular tachycardia and ventricular fibrillation, and during the transport, patient can collapse. So at that time, always a defibrillator should be attached whenever patient is being shifted for primary PCI.
So we at our facility, and I think everybody should practice the prevention aspects of it. So as we have the expert panelist, and you all can see that, handling cardiac emergencies are very important. So please go for the regular heart checkup, and then exercise, not to be refrained from the exercise, and daily walk, and pacemaker related, abnormal cardiac bradycardias and all can be just managed by, pacemaker implantation. Next slide. And I think, as we said, take these stairs, and EPS studies are also available with us. And now 29 September is going to be observed as a World Heart Day. So I think we encourage and urge everybody to just participate in marathon run. And we have come to the end of the session. And sir, would you like to just conclude the session by giving the message to the nurses, and we end there?
I think from a nursing perspective, the 2 important things is, one is the diagnosis of acute coronary syndrome. Like always, pre-ECG, you have to diagnose whether the heartburn is cardiac related or not. Once you're diagnosed as an MI, whether it's ST elevation MI or non-ST elevation MI, irrespective of that, you have to give the 3 important drugs. What you said, the mnemonic has to be followed. And along with that, the antiplatelet, what I said, like ecosprin 325, clopidogrel of 300, ticagrelor of 180, and rosuvastatin of 40 has to be given. Keep a cannula, see that the cannula is working well. It has to be double flushed, and see that the defibrillator is there along with that when you shift the patient to the cath lab. So I think these important things will save always, a person from, because we being cardiologists, we don't concentrate on these things. I think this is a nursing role which plays a very important part, in managing the overall scenario. So thank you.
Thank you, sir, and thank you for your very clear, concise, and very simple way of explaining to the nurses. And we have come to the cardiovascular series topic, which is going to be, today is the end of the session, and we have the next week the quiz based on the cardiovascular series. And thank you so much for your valuable time. Thank you, Deepika. We end the session now. Thank you.
Thank you.